The following podcast is part of a certified educational activity titled A New Era Has Begun in the Treatment of SCLC, Navigating Novel Therapeutic Options and Strategies for Improving Patient Outcomes. Access the entire activity and complete the post-test at peerview.com/UXH860. Downloadable slides and practice aids are also available.
Hello, this is Stephen Liu, Associate Professor of Medicine at Georgetown University. Welcome to this educational activity, which will focus on emerging systemic treatment options for advanced small cell lung cancer. Joining me in this discussion is Dr. Leora Horn, Associate Professor and Director of Thoracic Oncology at Vanderbilt University. Thank you for joining us, Leora.
Thank you, Stephen. I'm glad to be here.
Also joining us is Dr. Anna Farrago, Assistant Professor of Medicine at Harvard Medical School and Massachusetts General Hospital. Anna, thank you for being here with us.
Thank you, Stephen. I'm looking forward to the discussion.
So when we think of small cell lung cancer, certainly it's an area where there's much room for improvement. And in our discussion today, I'd like to start off with just some general perspectives and why are we here? What are the unmet needs for this disease? Anna, where can we do better with small cell lung cancer?
Yeah, so I think we've seen a lot of exciting advances in the past couple of years in small cell lung cancer, and we'll talk about those today. Some of them involve immunotherapies. I think one of our challenges right now is trying to understand who are the patients who are most likely to benefit from immunotherapies, and how do we use these best in the first line and then potentially beyond in the second line setting and afterwards.
Leora, what are your thoughts about that?
So I think that we've recently seen a new standard of care with chemotherapy and immunotherapy in small cell lung cancer, but what do we do for those patients who don't respond or progress on immunotherapy? What are our second line options and beyond?
Yeah, we definitely need to do better than we are, and I'm glad to see advances. Most of the advances have been in extensive stage. We have to remember that about a third of patients present with limited stage disease, where really we can cure some patients. Unfortunately, it's a minority of those patients. So how can we extend that cure to more than just the 1 out of 3 patients? And certainly we have some room to go with small cell lung cancer. We'll move on to the first part of this section. When we think of small cell lung cancer, this is a disease that accounts for about 13% of new cases of lung cancer in the US. It is a relative minority, but given the high prevalence of lung cancer, it's certainly a disease that affects many patients each year. There's a uniquely strong link to smoking, north of 90% of patients with some history of smoking. And based on that, there's quite a significant geographic variation. If you're in an area where you have a large tobacco use in your population, then your prevalence may be a bit higher. And I think that geographic variation extends globally as well. We're seeing different rates of small cell lung cancer in different parts of the world where smoking use may be actually on the rise up. While our standard staging system is the AJCC TNM staging system, I think most of us use the VA working group staging system. Do you guys agree? Is that the staging system you're primarily using?
We've started documenting their TNM stage in our charts, but in my mind, I guess because I'm old, I do go back to the old limited versus extensive stage disease when I think about a patient.
Now the TNM stage does maintain its prognostic value, and so there certainly is value in using the TNM staging system, but I think functionally most of us rely on limited extensive because it sort of guides our initial therapy.
Absolutely.
And what would your working definition be of the limited stage, Anna?
Yeah, for us it really comes down to whether the disease is localized within an area that can be treated safely with a radiation field. And I think that's interestingly evolved over time as radiation techniques have evolved. But certainly patients with disease outside of the thoracic cavity are considered extensive stage.
In our experience, about 2/3 of patients would be extensive, 1/3 limited stage. And I think the staging system is unique because for limited stage disease, while there are some sort of guidelines as to what is clearly extensive, limited stage really requires the input from a radiation oncologist because it is a tolerable radiotherapy port, and that definition varies certainly at all of our institutions, and even the same anatomic disease in a different patient with different lung function might be a different stage. When we think of small cell lung cancer specifically, Leora, what's your classic presentation? How do most of your patients with small cell present?
So small cell and non-small cell can have similar presentations. You know, the disease presentation is often determined by where the disease is. So patients with disease in the chest may have shortness of breath, cough, wheezing. Disease that has gone to bone might present with pain, liver, sort of the fatigue, malaise that you normally get. I think what's a little bit different is we seem to see inpatient consults for lung cancer that are small cell, not non-small cell. And it's one of those diseases where you will start therapy in hospital sort of as soon as you get the diagnosis, which is a little bit different from how we may approach a patient with non-small cell.
And in terms of when patients first notice that something's wrong to actual diagnosis, Anna, what's that timeline been in your experience?
Yeah, you know, I think that the pace of this disease in most patients is quite rapid. And because of that, patients will come in with a story that they were feeling well until a few weeks ago or until a month ago, but not over the past 6 months. You know, I think you see that the time frame is actually much shorter typically with small cell than with non-small cell. And to Leora's point, absolutely, I think we often need to start treatment urgently because we see that the pace of the disease is moving so quickly already at the time of presentation.
And that acuity, those significant symptoms, it's not just for late stage. When we think of limited stage small cell lung cancer, I think because this is such a central tumor, often obstructs either blood vessels or airways, and even limited stage patients can present with significant symptoms. For limited stage small cell lung cancer, our current standard remains concurrent cisplatin-based chemoradiation. I think that treatment course is characterized by very high response rates, north of 90%, with a significantly high rate of complete responses. But as we've learned over time, those high responses don't necessarily correlate to high cure rates. And so while we are delivering a potentially curative therapy, in reality, if we look at survival curves, the number of patients making it out 4 or 5 years, people that I would really consider cured of that disease, it's probably more like around 25 or 30%. And while concurrent really is our standard over sequential, we have to remember the difference isn't that significant. Not everyone's a candidate. Patients often have a lot of comorbidities, at least in our institution. I don't know if you guys experience the same thing.
We certainly do, and we have patients who are elderly or have certain comorbidities that complicate giving concurrent therapy. So if we can't give concurrent therapy, we will often start with systemic therapy and give 4 cycles of platinum etoposide followed by definitive radiation.
And Leora, is your standard here still cisplatin for limited stage?
For limited stage, cisplatin is still our standard, and then for patients with extensive stage, carboplatin. Even before the IO data was out, we were using carboplatin etoposide.
I would agree with that, but because it is a smoking-related disease, patients often have smoking-related comorbidities. Not everyone's really a candidate for cisplatin. I think even some of the current phase 3 trials for limited stage are allowing use of carboplatin, so we really need to see if there is a difference. As we said, even though we are treating definitively, most of our patients with limited stage will relapse, and the majority of patients present with extensive stage disease. So for those patients, really our backbone of therapy is platinum-based chemotherapy. And cisplatin etoposide, carboplatin etoposide, our institution is also a carboplatin. Some institutions in some parts of the world will often employ irinotecan. Anna, any thoughts on irinotecan use?
Yeah, it's one of the acceptable second-line agents. In the first-line setting, there is data showing that it can be equally active to etoposide. Certainly in a Japanese population, it actually showed superiority. I think in the United States and elsewhere, it looks equivalent to etoposide. And there are times where we may, for one reason or another, decide to use irinotecan, but mostly we're using etoposide as the partner.
We were actually using it last year when there was a shortage. When there was the etoposide shortage, we switched over to irinotecan for a while.
I think that both are certainly acceptable regimens, and what we see with either of those regimens is a pretty classic response, where response rates are very high, 50, 60, 70%, sometimes complete responses, even 10% complete response rate, but very short progression-free survival. And so in the initial studies that established cis-etoposide, PFS of 4.3 months, and if you remember, during 3 of those months, you're receiving chemotherapy. So really, as soon as you finish chemotherapy, that disease comes back. And in its initial state, it's responsive to almost anything. You can give a list of about a dozen different drugs that'll have a response rate of at least 30%. It's unique to small cell. But upon its inevitable relapse, it really is a very different disease. So there really is a dichotomy between the treatment naive and the relapsed small cell lung cancer. And so even though platinum etoposide seems like a very good therapy with high responses, very reliable and sometimes very deep responses, it has a lot of shortcomings, and really it is a transient benefit. But despite the poor outcomes, despite survival around 8 to 10 months, that has been our standard really for decades. But fortunately we have some new strategies, and I think that for the first time we can focus on some some major advances. Certainly in non-small cell lung cancer and other diseases, we've seen immunotherapy really change our landscape. Immunotherapy in small cell lung cancer, Leora, what were the reasons why we think this would be good in this disease?
So a lot of the diseases in which IO is approved are diseases that have high tumor mutation burden, and we saw that from data from the TCGA, and small cells kind of to the right of that curve. And so there was the thought that this is a disease that has high TMB, although PD-L1 expression is low. And so there was rationale to believe that this was a disease in which even we would see good single-agent activity with IO. The single-agent activity we're going to talk about has been okay. But I think part of it is that we still just don't have that perfect biomarker to help select therapy for patients, regardless of disease, with checkpoint inhibitors.
I think what we're seeing with most solid tumors, most carcinomas, is that there can be some very impressive responses, but clearly not everyone achieves those responses. And while we do need to work on identifying who those patients are, for patients without immunotherapy, anything new on the horizon that we should be excited about, Anna?
I think we've seen a number of advances recently in various approaches. One of those is PARP inhibitors and potential both as single agents or in combination with various agents. We've seen DLL3, which is a negative regulator of the Notch signaling pathway, emerge as a potential target, and I think there are some creative new approaches to targeting DLL3 on small cell lung cancer. And then we've seen some newer compounds come out, one interesting marine-based compound that we'll talk about later today that may function with a different mechanism than some of our traditional chemotherapies and again may offer a new strategy for approaching this disease.
Well, certainly there's been no shortage of ideas for small cell. We've known for a long time that our outcomes were poor, and so we've had many trials with very solid foundations that have just not translated into better outcomes. But I think that maybe for the first time in a long time, we actually have some very promising data to review for small cell. We talked a lot about chemotherapy and its initial response rates, but there are significant limitations with very predictable relapses and in its relapsed form, fairly resistant to most treatment, and the lack of improvement really for decades. Immunotherapy did show some promise, and I think we've all had patients that have done very well with immunotherapy. We now have some early data on pre-treated patients in second line and beyond. I think one of the earlier drugs explored here was the PD-1 inhibitor Pembrolizumab. And can you run us through the Pembrolizumab experience with small cell lung cancer?
Sure. So as you know, Pembrolizumab is a PD-1 inhibitor. It's been studied in two single-arm studies that I think are worth noting. One is the Keynote-028 study. This was a multi-cohort phase 1b study. It included 24 patients with small cell lung cancer. It actually required PD-L1 positivity greater than 1%. So in this study, 163 patients were screened, 145 had adequate tissue, 46 were positive, and 24 enrolled. So there was a real bottleneck in getting patients onto this study. And ultimately, it looked like about 31% of the patients who were screened were actually PD-L1 positive, so something to keep in mind. But of those patients, the response rate was 33%, and the median duration of response was 19.4 months, so impressive. The median PFS was 1.9 months, and the 12-month PFS was 23.8%. The overall survival was 9.7 months in that study. The Keynote-158 study is also one that I think we need to talk about. It's a single-arm phase 2 study of patients with previously treated small cell lung cancer, no prior PD-L1 selection required for enrollment into that study, but they did require archival tissue, which came in handy, and we'll talk about more. This included 107 patients with a primary endpoint of response rate. And the response rate in this study was 18.7%, and that included 3 complete responses. 73% of those responses actually lasted over 1 year. And the median PFS there, again, was short, 2.0 months, and the median OS was 8.7 months. But I think what we're seeing in these studies is that while, unfortunately, the majority of patients are not responding, there are a subset who respond actually quite well, and then once they do have very durable responses. And there was very nice data presented at AACR very recently that pooled the results from these 2 separate Pembrolizumab studies to look at the total of 131 patients included in both trials. And as we talked about, the eligibility criteria were slightly different for these trials, but still I think useful to look at them together. And overall the response rate was 19.3%. 9 of 16 responders had responses lasting greater than 18 months. So these are numbers that we're not used to hearing in small cell lung cancer. Really exciting and clearly showing us that there's a signal there. I think our job now is to try to really figure out who are those patients who are most likely to have those very durable responses.
I think these are really high quality responses. When you think of duration of response of 1.5 years, we're not expecting survival for 1.5 years with standard agents. But that PFS, it's so low. A PFS of 2 months really is your first scan. So why the big dichotomy there?
It's your first scan. And my sense clinically from treating patients is patients will respond to these or not. And I think if they don't, that you very quickly just see the disease grow right through immunotherapy. It's a little bit different than the field with chemotherapy, where maybe the response rates to second-line therapy are not high, but you can have a group of patients who have disease stabilization with second-line therapy for some time. The immune checkpoint inhibitors feel a bit different. It feels like either patients are going to have a very nice response and then potentially a very durable response, or the disease just grows right through it.
So more of an all or none. Have you ever seen pseudo-progression in these settings?
Maybe. It's hard to, I think that's a hard thing to really gauge, but I think that we don't typically get scans until 6 to 8 weeks in. I think there are certain circumstances where for some reason we will get a scan early, and those are the circumstances where we may see that a tumor looks maybe a little bit bigger or certainly no smaller, but then a follow-on scan shows a dramatic response. And I think that's the type of thing that where there may be a type of a pseudo progression happening before you actually see a response.
And when these first studies were being launched, I remember Keynote-28, there was some concern about small cell lung cancer because small cell lung cancer, like thymoma, we have a high incidence of paraneoplastic syndromes. And there was some concern that we would see a lot more autoimmune toxicity or paraneoplastic syndromes in small cell patients with IO. Have you seen that in your practice?
In my practice, I'd say we haven't seen complications that are really outside of the realm of what we would typically see with non-small cell. I think we now have a lot of experience treating our non-small cell lung cancer patients with immune checkpoint inhibitors, and I don't think that the small cell experience has been dramatically different.
Leora, for you, any anti-Hu type myelitis or encephalitis with IO in small cell?
I haven't seen it in small cell more than other tumor types, but I will say that because we know that the checkpoint inhibitors can potentially make that worse. For a patient who presents with autoimmune or a paraneoplastic syndrome, I'm a little bit weary depending, SIADH, we can manage that. Someone who presents with myositis or encephalitis, I'm a little reluctant to consider combining a checkpoint inhibitor. That's the patient I'd probably do chemo alone in.
That's fair. So what we're seeing with Pembrolizumab, sort of modest response rates, but the responses that we see are very high quality and certainly durable responses, and with time we'll see how long those do last. This is an agent that's not currently FDA approved, but is part of our NCCN guidelines after initial therapy. And we've got experience with other checkpoint inhibitors in this setting too. In fact, I think probably a little more experience with a combination of nivolumab and ipilimumab. Leora, you were involved in some of those studies. Can you tell us the differences or what you saw with that combination?
So Checkmate 032 looked at Nivo or Nivo-Ipi in patients with small cell lung cancer. The big difference to remember when we're looking at some of the data, that the data we're using with non-small cell of Nivo-3 Ipi-1 is different from some of the data we're seeing in small cell where the dose was Nivo-1 Ipi-3. And this study enrolled several hundred patients, found that the response rate with Nivo-Ipi was higher than Nivo alone. Nivo alone had a response rate around 10%. Nivo-Ipi had a response rate in the 20% range in the second and third line setting. The median overall survival as well was slightly higher with Nivo-Ipi than what we saw with Nivo alone. Nivo alone, the median overall survival was around 4 months. With Nivo-Ipi, it was around 8 months. And the grade 3-4 adverse events as well was higher with Nivo-Ipi, specifically the Nivo-1 Ipi-3, the grade 3-4 AEs were around 30% compared to around 10% AE that we see with Nivo alone. And similar with the Pembro data in some of the patients who were responding, we also saw responses that were quite durable. So again, figuring out those patients who should get this therapy is very important. And last year, Nivo got FDA approval in the third-line setting for patients with small cell lung cancer, although we know that the percentage of patients who actually make it to third line are probably a different group of patients. And so not many of our patients are likely to get third-line Nivo.
So I think it's important to have a third-line option, really the first drug approved in that setting. I think speaking more to the unmet need, because the response rate was relatively low. But there's a pretty high attrition rate with small cell. If we look at real-world evidence, there have been some data suggesting that only about 20% or less patients make it to the third-line setting. Has that been your experience in clinic as well?
So yeah, the patients who do well can often do well and make it to third, fourth, fifth line. Lots of different trials out there, which I think is also a testimony to the fact a lot of people said, well, there's small cell patients you can't get on studies. You can get on studies. We just need to have trials for these patients. But there is definitely a significant number of patients who don't even get beyond first-line therapy.
So a pretty high attrition rate. I think the third-line approval is good for patients, but clearly there's going to be a chance to make a bigger impact if we move that up. And that's generally our pattern of drug development. We try something in the heavily pretreated setting, move it up to second line, change that standard of care, and move it up to first line. But leave it to small cell to really sort of break that paradigm, because we've had some disappointing results in the second line setting. We saw Checkmate 331. And are you familiar with that study? Can you walk us through that?
Yeah, so that was a study in the second-line setting, as you said, where patients were randomized to receive either topotecan or nivolumab. Unfortunately, that study was a negative study. I think both for PFS and for OS, we did not see a benefit. And in fact, it looked like the topotecan arm performed quite well in that study, perhaps a little bit unexpectedly. And I think it's important to make a note of that as we sort of look to see what our standard is with our current trials moving forward in the second line setting and our current supportive care that we can provide to patients receiving topotecan. But certainly disappointing for nivolumab in that context.
I think disappointing is a good word. We saw similar outcomes in IFCT 1603. This was a non-comparative study, but the patients who received the Temozolomide had a response rate of only about 2%. So certainly not numbers that blow you away. They decided not to go to the phase 3 in that based on pretty disappointing results. Were you surprised by the second line data, Leora? Did you expect Nivo to beat topotecan?
Not necessarily on PFS, because we've seen in all the non-small cell lung second line studies with Nivo, with Pembro, and with Atezo, PFS was not better, but we did see an OS benefit. So I was a little bit surprised that we didn't see that OS benefit that we were hoping for.
Anna, is that how you felt?
I would agree. As we've discussed, patients will or will not respond to immunotherapy, so it's not surprising that the PFS was negative, but the OS is disappointing.
I really expected it to be positive, because I think of topotecan as such a low bar, but one seemingly that we can't pass. We also heard by press release the results of Checkmate 451. This, as we remember, is a maintenance study, and that maintenance approach I had great hopes for. I don't know if you guys did as well. But unfortunately, we heard that the combination of nivolumab and ipilimumab following platinum-based chemotherapy did not improve OS compared to placebo. And again, an area where I thought that there was going to be an advance. And so I was a little disappointed by those data as well.
I think it'll be exciting to see the data when it actually comes out, but I would agree that we were hoping that there would be some long-term benefit with the Ipi-Nivo.
So we have an approval in the third-line setting. Second line, we kind of didn't change standard of care, but we still looked at it in the first-line setting. And the first-line setting, I think, holds greater potential. Really, we know that this is really a different disease. Than in the front-line setting, it's much more responsive to other therapies. Perhaps we can build on that. Patients are generally in better shape with fewer chemotherapy-associated effects, or haven't had the long-term effects of therapy. And so that led to several first-line trials. And I think the one that read out, fortunately, last year really did make a big impact, where Empower 133 showed for the first time in decades an improvement in survival. Leora, you played a key role in that trial. Do you want to walk us through sort of that study design?
Sure. So the Empower 133 study, the rationale behind it was that potentially, as you get massive cell death, you get increased antigen release, increased T cell activation, and so potentially by combining the IO with chemotherapy up front, we could get better results. And so this was a randomized phase 3 trial that looked in patients who had no prior systemic therapy for extensive stage disease, Patients, importantly, were not eligible if they had untreated brain metastases, so that's a little bit different in how some of our patients present. And they were randomized to carboplatin and etoposide with or without atezolizumab for 4 cycles, and then the patients who were responding or had stable disease were able to stay on atezolizumab as maintenance therapy. There were 2 co-primary endpoints, overall survival as well as investigator-assessed progression-free survival, and then multiple secondary endpoints.
And I wanted to point out that unlike a lot of trials in the frontline space, this was pretty rigid in terms of its design. It wasn't choice of platinum, it wasn't 4 to 6 cycles, it really was carboplatin, 4 cycles specifically. And as we've heard, this really has changed our current standard of care. What did we see with the results in this trial?
So we didn't see an improvement in response rate. So unlike the non-small cell, when you combine a checkpoint inhibitor with chemotherapy, we saw improved response rates there, although one could argue it's a little bit hard to improve on a 70% response rate in the frontline setting. But there was a significant improvement in progression-free survival, as well as a significant improvement in overall survival. The median overall survival went from 10.3 up to 12.3 months, a hazard ratio of 0.70. And also when you look at some of the landmark analysis of survival at 12 months, there was a 13% improvement from 38% up to 52% for patients who got combination therapy.
And so we have, for the first time in decades, an improvement in survival. And this was really the first analysis, and hopefully with maturity that continues to improve, but really, I think, changing the standard of care. We have improved survival. What kind of cost did it come with? Did we see worse toxicity with this regimen?
So we didn't see increased toxicity, and the quality of life data has also been presented last year at ESMO IO. And there was data suggesting equal or better quality of life in certain domains. So we didn't come at the cost of increasing toxicities with the combination, which was good to see for patients with small cell.
Yeah, and I thought that a nice surrogate for how well tolerated it was when you looked at atezo versus placebo. They both received the same median numbers of doses of carboplatin and doses of etoposide, that giving atezo doesn't compromise your ability to really give 4 full cycles of chemotherapy, which more patients will get some benefit from. Anna, have you embraced this regimen? What's been your uptake of this between you and your colleagues?
Yeah, we have. I think the OS benefit with a hazard ratio of 0.7 is a real benefit. And we have now started to treat all of our first-line patients who are eligible for receiving immunotherapy with carboplatin and etoposide with the atezolizumab. One of the limitations of the study in some ways is that it excluded patients with brain metastases at baseline. And as you know, many of our patients present with small asymptomatic brain metastases. And I think there we have to use our discretion about whether we feel comfortable using this regimen in the first-line setting, despite those brain metastases that being there. I think before the atezolizumab data, we were certainly comfortable starting with carboplatin etoposide in that setting with close surveillance of the brain metastases and subsequent radiation in some cases. I think even with the atezolizumab data as it is, we would still consider starting with carboplatin etoposide and atezolizumab, and again, just watching those brain metastases closely over the course of treatment, and then potentially treating with radiation after chemotherapy is completed.
I mean, there's no data set, I think, that exists that perfectly captures the patients we see in our clinic, but is that an extrapolation you're comfortable with, Leora?
Yeah, we have a very similar approach, and don't forget in the study, patients, although many patients now don't get whole brain radiation because of some of the data that's emerged suggesting a lack of survival benefit with extensive stage disease, there were patients in the study who got PCI. So, and they did relatively well, and so I do think that, treating those brain metastases either at the end of chemo and atezo while they're on maintenance therapy, or if you need to treat the brain metastases sort of midway through, as we often do with chemotherapy, I think that is a safe approach, and that we have done that in some of our patients.
Another treatment strategy we sometimes see in small cell lung cancer, an extensive stage, is incorporation of consolidative radiation. And we saw from 133 that when you add PCI or when you add palliative radiation, it really didn't seem to introduce new safety signals, but we didn't use consolidative radiation in 133. So is that a strategy that you think is being done now, Anna?
Yeah, it's a good question. I think we do consider consolidative radiation in patients who have bulky thoracic disease and not a lot of extrathoracic disease. I think those are the patients who we think are most likely to benefit. And I think that now that we're using atezolizumab in the first-line setting and into the maintenance setting, we would still consider using consolidative thoracic radiation. We have to think a little bit about the risks there, and is there an increased risk of pneumonitis, for example, in that context. We have safety data from several studies starting to indicate that we can safely give thoracic radiation with immune checkpoint blockade at the same time, and the radiation dose that's used in consolidative radiation is not a definitive dose. It's a modest dose. So I think it's something we can consider, but we do have to be conscientious about thinking about the risk of pneumonitis there.
And what we saw in Pacific was that when we incorporate radiation and chemotherapy followed by immunotherapy, that we can really see improved outcomes. Should we expect something similar in small cell? Is there reason to be excited about that, Leora?
So I think it's a little bit different. We're not looking at early stage disease. Adriatic's going to maybe answer that question for us. But I think Pacific just kind of said to us that it is safe to give a checkpoint inhibitor in close proximity to radiation therapy and higher doses of radiation therapy than what you might do with some of the trials that are looking at stereotactic radiation therapy. I think the reality as well is that these drugs are in your system for so long. So unlike chemo, where if you stop chemo 3-4 weeks later, you can assume that the chemo is gone. With a checkpoint inhibitor, if you stop the checkpoint inhibitor, it's not gone. Many of the patients who have immune-related toxicities, those toxicities stay long after the therapy is given.
I think that we're operating sort of in a data-free zone when it comes to consolidative radiation. So maybe some potential risk, we don't really know. Maybe some differences in efficacy, or would you at least combine the benefit of the two strategies? I think we just don't know. We need a little more data there. I think what we're seeing with immunotherapy in general in small cell is pretty similar to non-small cell in some ways, that we are seeing a very high quality, durable responses in some patients measured in years, not weeks or months, but a fairly low median progression-free survival. Pretty big difference between duration of response and PFS, which really tells us that there's a small subset of patients that's driving most of this, a small group of patients who are deriving most of the benefit from immunotherapy. So it sets it up perfectly to identify a biomarker. And so what do we know about biomarkers used to identify these kinds of patients?
Yeah, it's interesting, and I think we'll talk about each of these, but each of the studies that have looked at immunotherapy so far have used slightly different biomarkers. So we don't really yet know across studies what the right biomarker to use is. I think the Pembrolizumab studies have been interesting. Keynote 158 looked at PD-L1, but rather than looking at PD-L1 the way that we typically do for non-small cell, which is a tumor positive score, here they're using something called a combined positive score, which not only scores PD-L1 expression on the cancer cells, but also on tumor infiltrating cells and other cells in the tumor specimen. And anytime that 1 out of 100 or greater cells expresses PD-L1, then that's considered positive. And about half of them were positive and half of them were negative. And what they saw was that outcomes were better with those who had a combined positive score that was positive compared to those that were negative. The response rate was nearly 36% in the PD-L1 positive group versus only 6% in the PD-L1 negative group, a striking difference. And there was a difference in progression-free survival. So it does look like this is an important biomarker. The difference also held up in overall survival, where we saw improved overall survival in those patients who were PD-L1 positive. But I think it's important to remember that this is a different measure of PD-L1 than what we use in non-small cell. This combined positive score is used in gastric cancer, so it's not something that pathologists are not used to looking for. But when we work with our pathologists, we have to really be careful to understand how they're scoring PD-L1 and how we should interpret those results.
And it can be difficult in small cell because a lot of times the diagnosis is made from a fine needle or from cytology, where really it's just a few cells. And if you're asking us to analyze stroma or look at anything related to architecture, you really need a better quality biopsy.
Yeah, I think so. I think that's a challenge.
So maybe PD-L1 by combined positive score could play a predictive role, both in the positive and negative sense for pembrolizumab in the pre-treated sense. So maybe we should be checking PD-L1. Did we see similar results with Nivo/Ipi in PD-L1?
So no, the results there were different. So when they looked at PD-L1 expression in Checkmate 032, they found that around 18% of patients were considered PD-L1 positive. So one or more tumor cells staining positive for PD-L1. But PD-L1 did not appear to predict full response. The differences that we saw in response were really with the combination Nivo-Ipi compared to Nivo alone, but PD-L1 expression on its own did not appear to predict for response.
So not a helpful predictive marker for response with Nivo-Ipi, but then maybe for Pembro, but sort of different assays, different approaches. Seems like we're still kind of learning. Any other biomarker data to think of, Leora?
So some of the other data that came out of Checkmate 032 was with TMB, and with that we saw that response was associated with high TMB. So as TMB went up and it was grouped into low, medium, high, those patients who were classified as high TMB, and this was by whole exome sequencing, had a better response than those patients with low TMB, and that actually translated into a survival benefit. Those patients with high TMB who were treated specifically with Nivo and Ipi had a very durable overall survival compared to those patients with low TMB. And even with Nivo alone, the high TMB story was not quite as clear. There was not as big a distinction in overall survival for patients treated with Nivo alone.
Much more with dual checkpoint blockade. So some interesting data for PD-L1. Maybe with a combined score, some interesting for TMB. You know, off study, do you feel like there's a role for these biomarkers? Are these things people should be checking?
Don't think it's ready for prime time.
No. Okay, so still sort of in evolution. When we think of the advances that we've made, I think these are very exciting data, and certainly we can do better, but I think it's nice to show, first, an improvement in survival in the frontline setting, and in the previously treated patients, an active drug that's really capable of delivering high quality responses. 133, I think we agree, has really set our standard of care. And so our current standard of care in the frontline setting, now FDA approved and preferred option in the NCCN guidelines, will be carboplatin etoposide with concurrent atezolizumab maintenance. We expect some large phase 3 trials to read out hopefully this calendar year. We have Keynote 604, which is really platinum etoposide and pembrolizumab. And then the Caspian trial, which is platinum etoposide with durvalumab and tremelimumab, or placebo. And so we'll see the results of those trials hopefully this year and hopefully provide more options. I think what we've learned from some of the second line studies and the maintenance trial is that saving immunotherapy for later may not be our best strategy, because second line immunotherapy didn't improve outcomes over chemotherapy, that maintenance didn't improve outcomes over placebo. But for patients who don't get immunotherapy in the frontline setting for whatever reason, Nivo is an option in the third line setting. And when we think about second line treatment, especially for people who've received atezolizumab and maybe didn't get that long-term benefit, our current approved option is topotecan. I don't know about the two of you, it's a drug that I really dislike giving. So clearly a need for more second line options. And if you progressed on atezolizumab, I'm not sure moving to pembrolizumab or nivolumab really makes any sense. Would you agree with that?
Definitely.
I agree.
So what non-immunotherapy options do we have for patients who progress after carbotope and atezo?
Yeah, I think we have several monotherapy chemotherapy options that can be used, but I think some of the newer data is actually giving us some more enthusiasm and looks like an exciting new direction. And one of those directions I think is PARP inhibitors. PARP1 and PARP2 are important in regulating DNA damage repair, and catalytic inhibitors of PARP are used, for example, in breast and ovarian cancer. But what we've seen is that recently data from Lauren Byers' lab and others have shown that small cell lung cancers are actually very dependent on that DNA damage repair pathway, and blocking it actually is an interesting new therapeutic avenue. There may be an association between expression of a particular biomarker, something called Schleffin-11, and sensitivity to PARP inhibitors. And that's come out of both preclinical studies and now some clinical data. Actually, the most exciting clinical data that we have in the second line setting is a study that was published in JCO last year, where it was a randomized phase 2 study where patients received either temozolomide alone or temozolomide in combination with the PARP inhibitor Veliparib. And that study saw an improved response rate with that combination, 39% with the combination versus only 14% with temozolomide alone. Unfortunately, the study did not meet its primary endpoint, which was an improvement in 4-month progression-free survival or an improvement in median progression-free survival, but there was a trend towards the Veliparib arm performing better. And I think what was very interesting is that the investigators were able to go back and look at those patients who received Veliparib and temozolomide and score them for having high Schlefin-11 expression or low Schlefin-11 expression on tissue samples. And what they found is that those patients with high Schlefin-11 expression did significantly better with that Veliparib temozolomide combination than those patients with low expression.
And this strategy of PARP inhibition is something you've done yourself. You had some data recently with a different PARP inhibitor, I believe.
That's right. So we conducted a single-arm phase 2 study of Olaparib, a PARP inhibitor, in combination with Temozolamide at MGH and Dana-Farber. We've enrolled 50 patients to that study and have seen a very nice response rate of nearly 42%, very much in line with the Veliparib and Temozolamide response rate of 39%. We saw a progression-free survival of 4.2 months. It wasn't a randomized study, so we don't have a comparator arm there, but I think both studies really support each other in showing that there is certainly some activity of PARP inhibitors, particularly in combination with the DNA-damaging agent temozolomide. There was some very exciting preclinical data actually that came out of Lauren Byers' lab just in the past few weeks showing potential synergy between PARP inhibitors and immune checkpoint blockade. So we may also see some other new combinations coming with PARP inhibitors down the line.
And tolerability in your mind?
You know, I think some of the common toxicities we see with these are myelosuppression, thrombocytopenia, anemia, neutropenia, and those are to be expected with both of these agents and generally manageable. These are things that we're used to managing as medical oncologists.
There are a few different strategies going on. I think it's an exciting time for small cell, and another drug that's getting a lot of attention, I think rightfully so, is Lurbinectedin. This is a novel marine-derived agent, sort of a synthetic complement to trabectedin, and this is a drug that inhibits activated transcription, really targeting RNA polymerase II, right, inducing DNA standard breaks and apoptosis, but it also has some role in the tumor microenvironment, I think with tumor-associated macrophages as well. So really a versatile drug that operates in a slightly different manner. We saw some results from ASCO last year showing that the drug is active, that when given by itself as monotherapy, a response rate of about 40% or so in the initial look, and we'll look forward to more updated data. We do know that that single-arm study did meet its primary endpoint, but I think that the most interesting data for me with Lurbinectedin was really that overall survival. In the relapsed setting, we saw an intention to treat overall survival of about a year, and that's really nowhere near what we'd expect with standard agents. What's been your impression of this drug?
Yeah, I think that the early phase data of this drug, both as monotherapy, as you indicated, and also some smaller studies that combined it with chemotherapies, all look very promising. I think it looks certainly active, and it'll be exciting to see how it performs in a randomized phase 3 study.
The phase 3 Atlantis trial expected to read out. This is a study for relapsed small cell where patients were randomized 1-to-1 to receive Lurbinectedin in combination with doxorubicin versus chemotherapy, either topotecan or CAV, and hopefully that'll show an impact in OS and PFS.
Yeah, I think the one thing to think about when we see this data is, yes, Lurbinectedin looked great with an OS of 12 months, but maybe we're just doing something better in managing our small cell patients, because Checkmate 331 had a median OS of 11.1 months with topotecan. So it'll be interesting to see where these drugs fall.
Certainly good to keep perspective. We need the randomized data, and small cell has certainly shown encouraging results in phase 2s, and when we get to phase 3, it certainly has been known to fizzle out. So agreed, we'll temper our enthusiasm until we see larger data. But you know, apart from immunotherapy, some of these newer agents, when we think of the advances we've made in non-small cell, I think some of the biggest advances have really been with targeted therapy. For small cell, the genome is pretty bland. You know, we're looking primarily at loss of tumor suppressors, and really driver mutations, but it doesn't mean that there aren't targets, right, Leora?
Yeah, so one of the targets that we've heard about the last couple of years is DLL3. And so DLL3, as Anna mentioned before, is a negative regulator of the Notch pathway. We see increased DLL3 expression in around 70% of patients with small cell lung cancer. And it's also broken down in sort of to low, medium, and high DLL3 expression. And one of the drugs that targets this pathway that we've heard quite a bit about is Rova-T. So Rova-T is an antibody drug conjugate. So these drugs, we think of them a little bit differently. Maybe there's a smarter delivery of drug to the target. They're an antibody. They have a linker that binds to the tumor cell, and then you get release of the cytotoxic payload into the tumor cell. But the initial excitement with Rova-T has sort of died down with the results that we've seen from the phase 1 study. The response rate was only around 14%. The median progression-free survival was only around 4 months, and the overall survival was less than 6 months in the Trinity trial. And we've also heard that the Tahoe trial closed, which was in patients with relapsed small cell lung cancer, comparing Rova-T to topotecan. Again, it was a negative study, and so the only study that we're waiting to hear more about is the Meru study, which looks at platinum-based chemotherapy, and those patients who have stable disease or response to therapy, they're being randomized to Rova-T or placebo. I think it's a hard trial to actually imagine that you can even have a placebo in. You can see the toxicities with these drugs. They're very unique, specifically the serosal toxicities with edema, pleural and pericardial effusions, but hopefully we'll see some data with that compound come out in the next year or so.
Now, DLL3 has all the makings of a good target. I mean, it's expressed preferentially on tumor cells, doesn't really seem to play much of a role in our adult normal cells, but it didn't seem like this drug was a perfect fit for this setting.
I think one of the challenges with this drug was the toxin, which was a PBD toxin, a very potent DNA damaging agent, and I think a lot of the toxicities, the effusions and thrombocytopenia associated with Rova-T are related to that toxin. So I think if DLL3 can be targeted with other strategies, that may really open up some new possibilities.
And we're seeing some of those strategies come out, where there's AMG 757, which is also an antibody drug conjugate against DLL3, and then AMG 119, which is a CAR-T like therapy against DLL3. So hopefully we'll see some new options for patients in the future.
It's certainly exciting to hear about CAR-T moving into small cell lung cancer.
Yeah, real dynamic treatment, so hopefully we'll be able to deliver that in. But if we look big picture, 5-10 years down the line, hopefully we're not doing the same thing we're doing now. What's the future hold for small cell lung cancer? What's our next big advance here?
I just came from the ISLAC small cell lung cancer meeting, and one of the themes that emerged there from the preclinical side is that we are now starting to appreciate there are different molecular subtypes of this disease. So we've always thought of small cell lung cancer as this very homogeneous disease. All patients kind of go down the same path of treatment options. But really there are subtypes. There's an ASCL1 high subtype, it's a particular transcription factor, and then a separate subtype that expresses a different transcription factor, NeuroD1, and these probably have different biologies and probably ultimately different optimal therapies. So my hope is that in 5 to 10 years we're not thinking about this as a uniform disease across patients, but that we're thinking about it more the way that we think about non-small cell lung cancer, where we can subdivide it into subtypes and choose the best therapy based on the individual patient.
I think that we don't make any big advances really without a large-scale investment in the biomarkers, really trying to be more rational with how we treat this disease. I think we've talked about quite a bit for small cell lung cancer. Maybe we can move on to the third part, which is our practicum. Case one is a 59-year-old female smoker who presents with dyspnea and cough. She's found to be hypoxic in the emergency room, I think a fairly typical presentation. She has a CT scan that shows a large mediastinal mass, multiple enhancing liver metastases, and her MRI of the brain with contrast showed a 1 centimeter brain metastasis. She had no headache or neurologic symptoms, was admitted to the hospital where a liver biopsy revealed small cell lung cancer. So I think this is a fairly typical case and highlights a few important points. One is the rapid nature of this, and I think it's not uncommon, at least at Georgetown, to really treat patients on an inpatient basis. Is this something you run into in your situation?
Yeah, absolutely. This is a patient who's at risk for real respiratory compromise if this patient's not treated quickly. And we will often get therapy started in the hospital, as you said. It's interesting now to think about how we incorporate our new standard, carboplatin etoposide atezolizumab, with these inpatients. Sometimes getting immune checkpoint inhibitors started on the inpatient setting is more complicated for various reasons. And what's important to remember from Empower 133 is that the response rates were the same for the control arm and for the arm that received atezolizumab. So in my practice, if I have a patient like this, I'm very comfortable starting the first cycle with carboplatin etoposide, which can get started within the same day on the inpatient setting in most cases, and waiting and adding the atezolizumab in the second cycle. I don't like to delay the atezolizumab any longer than I need to, but if there's an urgent start to in an inpatient setting, I think we can drop the atezolizumab and feel okay about that.
I think it's an important point because sometimes it really forces you to act quickly. Just because you don't give the atezo with cycle 1 doesn't mean you need to wait until relapse or progression. You can really fold it in right with cycle 2, and that's generally been our practice as well. And what was different about this patient, as opposed to 133, is the brain metastasis. We talked a little bit about this. This patient would not have been eligible for 133. And so would you feel comfortable treating this patient? How would you fold in radiation, if at all, Leora?
So this is a patient who's going to need whole brain radiation. You know, we don't think about doing SRS in small cell lung cancer patients. And those patients generally will have more than one brain met. You just probably can't see the rest of them on the MRI. And so if the patient's asymptomatic, there's not a lot of edema, I would follow their brain met with imaging and get radiation oncology on board up front when you see that patient. That if you scan them after 2 cycles, and I would scan their brain as well, if the brain is shrinking, which often small cell you will still see a response in the CNS, with even when we just had chemotherapy, sort of complete the chemo and then do the whole brain radiation. But if there's any changes in the brain, I would be sure to add in whole brain radiation in the middle there.
Similar approach, Anna?
Absolutely.
And then afterward, let's say you have a complete response. You do radiation, complete response in the brain. Do you still monitor the brain, or what's your strategy for surveillance there?
You know, after radiation, we don't necessarily continue to monitor the brain. If we have a patient who has not undergone radiation for one reason or another, either they're not a good candidate for performance status reasons, or radiation is not considered safe because of comorbidities, then we will certainly actively survey the brain at least once every 3 months.
Or a similar strategy?
Yeah, NCCN put that in their guidelines a while back for patients after the Japanese data came out, suggesting that if patients don't have brain mets, that whole brain radiation may delay development of brain mets, but doesn't improve overall survival. Most of those patients will get an MRI brain every 3 months.
I think some important points with that case. Maybe if we move to an earlier stage case, I think that there are some subtle differences between extensive and limited stage. Case number 2 is a 62-year-old male smoker who presents with dyspnea and facial swelling. Has a CT scan that shows a mediastinal mass compressing the superior vena cava, undergoes bronchoscopy with biopsy, which reveals a diagnosis of small cell lung cancer. Brain MRI shows no metastases, a PET scan shows no extrathoracic disease, and so what we have here is limited stage small cell lung cancer that is fairly symptomatic. What would your approach be for a patient like this, Anna?
This is a patient who I would try to see with my radiation oncologist from the very beginning. This is a patient that requires multimodality care, and put together a plan right up front for ideally concurrent chemotherapy and radiation. Now, radiation takes some planning. It can't get started immediately. So often what we'll do is start the patient on chemotherapy, do the radiation planning, and then add the radiation with the second cycle of cisplatin etoposide. And I think there are several meta-analyses supporting adding radiation sometime within the first 2 cycles and having that be an acceptable approach. What we don't like to do is delay the radiation until after the second cycle or even later, unless we have to for reasons having to do with the patient's comorbidities or performance status.
Are you comfortable with that, Leora, that chemo and radiation don't have to start cycle 1, day 1 together?
Yeah, it's not infrequent where you'll see small cell lung cancer patients where they've just got bulky disease. And it's not that it's from here down here, it's just there's a large mass. And our radiation oncologists will look at the scan and say, well, radiation is going to be safer if we could just shrink that a little bit. So it's not uncommon with these patients that we'll do their first cycle of chemo and then add radiation with the second cycle. I think different from non-small cell as well, as we're doing 4 cycles of chemo with radiation, whereas in non-small cell with the cis-etoposide, we were often starting up front but stopping after 2.
Yeah, I think it's a good point. I'm very comfortable. In fact, most of the data is for starting with cycle 2. And most of our randomized trials, just knowing the logistics of quality controls radiation, not something you want to rush through, that really starting with cycle 2 is perfectly acceptable. I think what you want to avoid is someone, he's symptomatic, SVC syndrome. You don't want someone to give palliative radiation, sort of lower doses of radiation, because you really burn some bridges in terms of delivering a definitive dose. So I think the worst thing you could do is give low dose radiation just because he's symptomatic, knowing that this patient is going to feel better once we give chemotherapy, that there's a high response rate. You really want to be able to deliver definitive, potentially curative doses. We talked a little bit about prophylactic cranial radiation. We know that the brain is a reservoir site for limited stage, and are you using PCI?
I'd say the data are more compelling for limited stage than for extensive stage, certainly for using PCI. In our patients who are young and very good performance status, we will certainly have that discussion with them and include the radiation oncologist, of course, in that. I think for our older patients or patients who are poor performance status, We may shy away from PCI in that context. If that's the case, then I do follow those patients with brain surveillance, as we've talked about.
Now, PCI was, for years, our standard in extensive stage, and you mentioned a little bit about this, Leora, because early data looked at PCI in extensive stage and in limited stage and really showed not just a decrease in brain mets, but a difference in survival. Now, that data has been challenged, right?
Yes, the biggest issue with that initial study by Slotman and colleagues was that the patients who were enrolled in that study didn't have imaging just prior to enrollment. And so the Japanese study looked at patients with extensive stage disease, got an MRI, and if those patients did not have brain mets, randomized them to prophylactic cranial radiation versus no radiation. The important part is, as Anna mentioned, that limited stage disease was not included in that study. There is a study, I believe, that's being developed that's going to be looking at that question of what to do with patients with limited stage disease. But for those patients, we are definitely having that discussion of PCI, and for the young, healthy patients who we think can tolerate it, offering PCI.
Yeah, I think the concern here is that it's not necessarily a benign treatment, that there is toxicity in terms of neurocognitive effects and memory loss, and that can really affect quality of life. So certainly, I think, an important issue.
I think it was striking that in that Japanese study, actually, the patients who received PCI after treatment for extensive stage small cell trended towards poorer outcomes, actually, than those who didn't. But in the control arm in that study, they were doing ongoing surveillance of the CNS every 3 months. So that's why I think it's critical that if we're not giving PCI to our patients with extensive stage disease, then we are committing to doing active surveillance.
Mm-hmm.
Our last case is a 62-year-old male smoker with limited stage small cell lung cancer. He receives concurrent chemoradiation, cisplatin etoposide, radiation to 64 gray, has an excellent response. This patient opts to receive PCI and has a surveillance CT scan that shows, unfortunately, recurrence in the lung, liver, and bones about a year later. If we talk about recurrence 1 year after chemoradiation, how would you manage this patient, Leora?
So once we've got that biopsy to make sure that we are dealing with small cell again.
An important point. What else would it be?
Well, patients can develop other tumors. So, we can't always assume that we're dealing with the same tumor, although the majority of patients with small cell will recur in the first couple of years after therapy. This is a patient who's got platinum-sensitive disease because they're more than 6 months out from their initial platinum-based chemotherapy. And so I would give them carboplatin, etoposide, and Temozolomide. I think that this is a patient who, assuming they tolerated it the first time, is someone that I would definitely consider for a platinum doublet with atezo at recurrence.
In fact, he would have been eligible for 133 because it was greater than 6 months out. So I think the data do apply. But what if he was having surveillance scans and had recurrence only in the brain? Say this patient did not get extracranial recurrence, but really just recurrence in the brain after PCI. How do you manage that situation?
Yeah, that's a tough situation. I'd say it depends. I certainly try to avoid repeat whole brain. I think that can be very, very debilitating for patients. So I try to avoid that at all costs. I think that if there's an isolated metastasis in the brain that's treatable with SRS, then SRS is an option, followed by ongoing surveillance, although at that point you're really expecting that the disease will continue to progress elsewhere as well. If there are multiple sites that are really not amenable to SRS, then I'd probably, rather than repeat whole brain, would favor moving to systemic therapy. And I agree with Leora that this is a patient who I would like to offer carboplatin, etoposide, and Temozolomide, and hope that that also has the potential for a durable response given the addition of the Temozolomide there.
Let's change the case a little just for discussion. Let's say this patient receives cisplatin etoposide with radiation, PCI, and then his first scan within 1 month shows diffuse progression. Right? So now we're talking about really a chemorefractory small cell lung cancer. How would you manage that patient, Leora?
So that's a patient that I actually might think about using Nivo or Nivo-Ipi. The one subset analysis from Checkmate 331 did show that there was some benefit with Nivo alone in the platinum refractory patient population compared to the platinum sensitive population. Of course, topotecan is always there as a potential option, although we know it doesn't work well in patients with platinum refractory disease. And then, of course, Pembro is also a potential option. In my mind, there's not much difference between Pembro and Nivo, although the studies are giving us different reads. But in terms of their mechanism of action, I would probably go to a checkpoint inhibitor in that patient. Clinical trial, of course, always being the right answer first.
Anna, your thoughts?
Yeah, no, I agree, and I think that bringing up the option of a clinical trial is really important. These refractory patients are difficult to manage because we know that their likelihood of responding to a cytotoxic monotherapy in that setting is quite low.
I think it's important to convey, really, this is a very poor prognosis. I think that you would argue that really no agents have shown really significant improvement in outcomes in that setting. Topotecan in the chemo-refractory setting, really a pretty bad drug. And so clinical trials always our preferred option, not just to move the field, but really often the best option for the patients. But there have been a lot of challenges when we talk about clinical trials for small cell lung cancer. We see these large, rapidly accruing studies for non-small cell, maybe a little different in small cell. Why is it harder to run these trials?
So, I think some of it has been advocacy. The reality is if you look at the IO studies, they've accrued like gangbusters, and we've got patients, they've opened and closed at some institutions faster than what you can put patients on trials. So I think it's getting the word out that there are new therapies, getting rid of some of that therapeutic nihilism, and also getting companies interested in exploring small cell lung cancer because it hasn't been as an attractive target, so to speak, for many companies.
Yeah, I think the fact that there are more trials also is helping actually recruit more patients to academic centers. I think this is a disease that traditionally there haven't been creative options for managing these, so these patients can be managed in the community just as well as they can be managed in an academic center.
Just as poorly.
Well, unfortunately, but I think now that our options are improving on the clinical trials front, and there's a lot moving from the preclinical side into the clinic now, there's more reason to send patients in for a second opinion or to get a referral for consideration of a trial.
But I also think one of the big challenges with small cell is just the pace, the acuity, and when we talk about non-small cell, a lot of it's biomarker driven, and if biopsies are inadequate, you go back and do another biopsy, but a lot of times for small cell, it won't give you that delay, it won't accommodate those delays, and so the sparse tissue from that initial biopsy might not be enough to really study the cancer, and biomarker-driven studies, I think, are particularly challenging for small cell. I think the other unique thing about small cell, compared to maybe other tumor types, is that there really is a strong focus on our multidisciplinary team. And so there are key important members to this team. You mentioned that you're ideally seeing people with your radiation oncologist. Right? And so talk about that relationship.
I work very closely with our radiation oncologists. We not only see patients together at the time of initial diagnosis, but often in follow-up we see them together too. I think it's important to remember that we utilize the radiation oncologist not necessarily just at the beginning, but also as the disease progresses. There may be a role for palliative radiation or SRS, as we've talked about, in certain situations. So I think that's an important relationship for us to maintain as a medical oncologist with that colleague, but also for the patient to continue to see that person along the way to know that they're a part of the treatment team.
Any other members of your team?
Well, it really is a whole healthcare team. So pulmonologists getting those biopsies for us, even if you think, or radiology, that it's small cell, it doesn't matter, get a big chunk of tissue because you never know where that tissue is going to come in handy. And then we know with non-small cell lung cancer patients from some of the data from your institution that survival may be improved with early referral to palliative care. The data's not out there with small cell, but getting palliative care providers involved early on, we're lucky enough to have them in the clinic with us as well. I think that anything we can do to improve quality of life for our patients is important.
We talked a lot about small cell lung cancer. Leora, what are the key takeaways for our oncology colleagues?
So, I think we have a new standard of care for patients with small cell lung cancer, but it's not enough. And I think that there are a whole host of new drugs and new trials that are out there. And so you may get your first line therapy out in the community, but don't forget that there are trials and there's a lot of options that we're exploring for this group of patients.
Anna, anything to add?
Yeah, I would just add, as we've mentioned, it's a disease that requires a multidisciplinary team. Even though it's not a surgical disease, it's a disease that involves a radiation oncologist frequently and others, as we've discussed. And that's, I think, how we can provide the best care to our patients.
And I think that although we've seen a lot of advances in small cell, I think it really just commands a healthy respect. And it often doesn't behave as we think it would or think we should. And so there are plenty of patients that come in that really look like they're going to do well, that you think that I can maybe wait to do immunotherapy later, I can do some delays, I can try to be clever in the approach. I think we need to stick with what is improved outcomes. And for us right now, the standard platinum etoposide atezo, but really early referral for trials. Even if patients are receiving carbotopo atezo, sending them to see Leora, to see Anna. I think any patient would love that, and really getting plugged in so that if relapse does occur, that they're already known to the system, that we can start planning ahead. I think that really is important. Well, I want to thank both of you for joining us today, for sharing your expertise with me and with our audience. And I hope all of you listening and watching have found this discussion both informative and useful to your practice. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UXH860. This activity is supported through independent educational grants from AbbVie, Bristol Myers Squibb, and Genentech. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.